Good morning. Welcome back to 1160 AM KBDT News Talk Sports. Hey, don't miss Wayne Allen Root, raw and unfiltered, this afternoon from 5 until 8 p.m. only on 1160 AM KBDT News Talk Sports. And again, our very own Wayne Allen Root got tweeted by the president for all that he says and how unfiltered he is about defending the president and his policies. And so, Wayne Allen Root, you're the man. You the man. And I love calling him
you demand.
The Root.
Even though he goes by War Now.
Yeah, I know, but I still love The Root.
Okay. Well, you know,
it sounds impressive.
Whatever he's doing, he's getting tweeted by President Trump.
Yep.
You go with your bad self.
You go with your bad self. All right. So don't forget, stay tuned in the next segment, the Mental Health Moment, brought to you by our very own Something for Kelly Foundation, the Morgan Foundation. We are going to have a fantastic professional on this morning out of Vanderbilt University. Dr. Hollon will be joining us. Adult depression. And this is something that is rampant. I'm going to tell you, I know lots of adults who are very high, very, very intelligent, degreed people, professionals.
I'm so glad you said this. Struck
with depression.
I'm so glad you mentioned what you just mentioned, because this is something I've wanted to say the last few Tuesdays and I haven't remembered to say it. Your being mentally ill has nothing to do with your intelligence. Some of the most brilliant, well-read, well-studied, most unbelievably intelligent people are struck by bipolar or depression or something of that nature. So this has nothing to do with the intelligence level. I'm so glad you said that, JP.
Yeah, I mean, and depression can strike at any time. Depression, and I'm hoping what we find out at some point is, what are the different types of depression? Because there's a lot of that out there. And
right.
So anyways, let's get on back to sports. So tune in at 8:34 for the Mental Health Moment. Going to have a fantastic guest on from Vanderbilt University. All right, college football. Again, here's my rant, and I'm going to do this for just about a minute. Why is it that University of Texas goes out of the top 10 when they lose to LSU by a touchdown? They should have converted in the red zone to beat LSU, but LSU is ranked higher than they are. We lose by a touchdown and we drop to 12, and Utah somehow replaces us. Of course, Utah then embarrasses the AP poll because they get smoked this weekend, and they're horrible, but somehow they become number 10. Texas, again, loses by a touchdown. We drop. We're number 11 now. We've moved up one after a great game on Saturday against OSU. And again, OSU is one of those that every year can upset a Texas or Oklahoma, because OSU just seems to have that presence about them, especially when you're playing in Oklahoma. And so OSU didn't upset Texas. Texas goes number 11. Notre Dame, how do you fall from number 7 to number 10 when you lose to a team, again, ranked number 3, and you lose by a touchdown?
And especially because you're Jesus's team.
Well, and you're Jesus's team. I mean, so how does this happen?
Yeah, when I saw that, I was like, are you kidding me?
And I understand the ACC is ranked number 1, but I almost count Clemson as part of the SEC anyways. But your number 2, 3, 4 team is the SEC. Come on, give me a break here. LSU's defense is riddled with mistakes and issues. I mean, how do you allow a almost Division II, Division III team to score 36 points on you? I mean, come on, give me a break here. And then Ohio State, that's another joke. I'm glad to see Michigan got kicked out of the top 25. Boy, do I sound angry?
You do. And you're going to sound really angry after I talk about my fantasy football scores from the week.
No, I'm not. Because,
Okay.
again, it was all set up for you to win. You see, I was hijacked. You got with another fellow woman who didn't want a man to win fantasy football. And so you guys bifurcated my draft. Oh, I can't prove that?
You can't
Interesting
prove
that my draft was bifurcated. And who was the commissioner? Your little good buddy, Michelle.
She's your good buddy, too.
And you know what her directive was? Don't allow JP to control the draft. Interesting. Okay, fantasy. Go ahead, fantasy.
Okay, well, first of all, and this is insane. Like, I've heard that, and again, since I'm so new to this, I've got a friend of mine who I've been showing my scores to, and he's like, wait a second, I've been getting like consistently over 150 and 160, which supposedly is very high scoring for fantasy football. So how does this happen? So Team Mystery, which is aptly named because I have no idea still how I accidentally drafted this team, because I drafted this team before I actually drafted our regular team. I scored 202.52 points and dominated my opponent in that league. They only had 101.96. And then the Angry Unicorns, who were actually predicted to lose by a couple of points, I won 164.78 to 127.66. I'm 3-0 in both leagues, baby. Just saying.
That's what happens when you control the draft.
I did not.
It's interesting
But
how I was
might
drafting
not
for
have had a
two teams
secret
by
weapon.
accident. What was your secret weapon?
I can't say until closer to the end of the season.
Your commissioner. That's what your secret weapon was.
No.
As I got
Michelle.
jacked.
Was not Michelle.
Yeah, now I'm in depression. I need Dr.
Just say,
Hollon.
go,
for
Kathy,
sure.
go. Yay.
We'll be right back.
Yeah, the irony. So what I keep doing is taking screenshots. So I've got a lot of guy friends who have played fantasy football for
Explain to me
decades.
how you're getting the points.
I don't know.
That's what I want to
She's cheating. All right, mic test.
Coach, I have no
Let's do some mic
idea.
tests. Hold on.
But
Mike.
what I do is I take screenshots of these.
All right, mic
And
test.
especially, the angry unicorns.
Test 1 2, test
That's
1 2.
With my logo.
Okay.
Hello,
Patty?
hello,
And I
test,
send
test,
it
test.
to all my
Hello,
buddies who
it's
a
good.
lot of them like pay to play.
Hello.
fantasy
Do I have her
football.
on or
And
not?
I'm like,
It
if you
sounds
need
like it.
any tips, I seem to be
Okay.
pretty good at this.
Good.
And they're like,
You know that unicorn that I wanted to give the Piper? There was like nobody
So-
called in of it. Remember for like
Casey
Oh,
Blake,
oh, I
you're
know.
really close to the
Really
mic.
close to the mic.
I'm doing
All
it.
right.
I'm
He's on the
calling
feed
it.
right now watching. He
Very
has
close.
family,
Okay.
Yeah.
several friends, unknown,
Yeah.
but are going to be very good. So everything I
Is
would
that
ask
me?
for.
You can't do that. I'm sorry.
Oh, I was like, is that me?
Yeah.
Oh, it's the headphones near the microphone.
Yeah.
Oh,
Got it.
wait.
So they're going to do the Christmas train. Sorry about that.
So he's taking a picture and a write up, and he is going to
Thank you.
Go to the Polar Express.
How
Wow.
much fun
The
is
Polar
that?
Express is in
Wow.
what's the name?
So
Palestine.
Oh,
And
how
they
What-
wear
Very
pajamas
excited.
and everything
What
gets
appointments do you have
ridiculous.
today
So-
My
after
mom
the
took
show?
kids
I'm
to that
working.
when they
In
were
fact, I
little,
leave
that
here.
she used to do
I'm
Thompson's
going to be
train with
leaving
them.
you
My
at
son
like
was obsessed with
8:50.
trains. And they
Oh,
do
okay.
Polar
Back out of
Express, they
Lacey
saw
Prep
those little
Academy.
bells.
Yeah.
We put them on the tree now.
Yeah.
what are you doing?
Oh, that's
tonight?
so cool.
They're gonna take
Having you take me out
Oh, that'll
for a
be so
steak at
fun. That'll
Del
be so
Frisco?
fun.
Because we take them to the Galveston. And it's
My
station
vegetarian
one at the
father
end of
will
the line.
appreciate that.
Oh,
It's on
yeah.
Santa Fe.
They
Yeah.
got
Galveston, so Piper loves to go.
French fries he
That's
can eat.
awesome. That's awesome. How fun.
You're bad. I just want you to know that.
There used to be a song about that. I think Michael
Oh,
Jackson
yes.
did it years ago, back when he was still Michael Jackson.
Right?
Yeah.
Coach,
What about Michael Jackson?
Listen to your college on
I think he did a song
college
named
freshman.
Bad.
Oh, yeah. Well, what were we talking about him when he's still my, before he started having all the plastic surgery?
I didn't know. Yeah, admittedly,
Wait, what?
it is.
Oh, we've got, hello.
Hello?
We've got our guest on the air. How are you this morning?
Doing very well, thank you. How about yourself?
Good. Doing well. Thank you so much for being on our show.
My pleasure.
Steve, hi. You've got Steve down here again. Thank you
Hi, Steve.
so
Good to talk to you
so
again.
much.
Yeah.
You too. Absolutely.
Surely.
Excuse me. Did you have a chance to look at the brief outline I sent you yesterday?
I did.
Okay, good. Yeah, we'll just try to hit those hot spots. I think we really want to hit the preventive aspect hard as well. That's going to have a lot of interest to the
Absolute to our
listeners,
audience,
yeah.
definitely. And again, thank you so much for being with us.
Pleasure.
Good morning, Stephen. This is Patty Giola with the Something for Kelly Foundation. Thanks for joining us on the Mental Health Moment this morning.
Hi, Patty. How you doing?
Doing well. Looking forward to your conversation with Steve. He's
Cool.
got a lot of great questions lined up for us here
He
today.
does, yeah. I
And
wish I had answers.
details.
We feel quite confident that you
Yeah.
will.
1 minute.
So Stephen mentioned to me that your work has been cited in over 26,000 different articles, and I thought, gosh, at some point they can stop counting, right?
Right. That's right.
Miss Texas 2017. You like
Stephen
So
A.
if you take out the self-citations, it drops.
Bingo.
Okay,
She's
and
actually
just so I'm sure,
following
how is your last name best
Yeah.
pronounced?
She graduated from Baylor.
Yeah, it's Hollon. Almost like you could say the country,
Miss
except there's
Texas
no D in
from,
it.
2
Except
years
without the D.
ago.
Okay, great, great.
Love her. Caroline Carruthers. She was at Baylor, graduated from there as a twirler there, and now she's over at
This
UT.
one's from Houston, right?
Yeah, this was from Houston. Yeah, this is like 2017 Miss Texas.
Ten seconds.
Good morning. Welcome back to 1160 AM KBDT News Talk Sports. Classic radio of the past, replayed in the present. Don't miss Classic Radio Theater with Wyatt Cox tonight from 8 a.m. until 11 p.m. only on 1160 AM KBDT News Talk Sports. It is currently 8:35 here in the Metroplex. Having a good time. It's going to be hot, super hot, humid hot, way hot, bad hot. It's going to be so hot, you'll want to turn your air conditioning on.
Hot and hot tub. I know what you were doing that old Saturday Night Live skit.
Yeah.
Yep. That's good. That's funny.
Hi, thank you.
You're welcome.
Squirrel Girl.
I know.
I love it.
You make it too easy.
I do. Good morning to Dr. Steve Hollon. Good morning, sir. How are you?
Good morning. How you doing?
I'm well, thank you. Thank you so much for joining us here on JP, Kathy, and the crew.
My pleasure.
How is the humidity in Tennessee?
It's a little cooler this morning. It's not quite fall yet, but it's going to get up in the 80s this afternoon, but cool this morning.
Very good. Well, thank you again for joining us. This is brought to you by the Something for Kelly Foundation and the Morgan Foundation. We're calling this our mental health moment, and where we talk about real hard-hitting mental health, mental illness type issues that even may relate to eating disorders. And then what are some of the solutions that we're looking for in dealing with a lot of these topics? And of course, today's topic is going to hit right at home. And I'm going to turn it right over to Steve Dunn with the Morgan Foundation. Steve, I mean, what a great topic. What a great guy to bring on today.
Absolutely. We are thrilled to have him here today because of how prevalent depression is. According to the National Institute of Mental Health, over 17 million adults suffer from depression, and that does not include the kids and adolescents, of
Steve,
course.
say that number again, because that's a staggering number.
Over 17 million adults. And
Wow.
again, that does not include kids and adolescents, of course. So our doctor, and again, thank you for being on board with us today. He specializes in not only the treatment but the prevention of depression. So to jump right in, doctor, is depression treatable?
Yeah, it absolutely is. It's one of the most treatable of the psychiatric disorders. The real problem is that a lot of folks who get depressed don't seek treatment, but only about 4 in 10 do, and that's up from about 20% 25 years ago. But it's still it's very readily treatable disorder, and the problem is that not enough folks know that.
Okay, so when you say we can treat this, do we call it a disease, illness?
Yeah, I wouldn't myself talk about it as disease per se. There are two major forms of depression. What we have is unipolar depression, where the person gets depressed, but only gets depressed, and then bipolar disorder, where the individual not only has episodes of depression, but also mania or hypomania, which is virtually the opposite, excessive good feelings, etc. And unipolar depression is extremely prevalent. The single most prevalent psychiatric disorder that at least 20% of all women, at least 10% of all men going to meet criterion, and that's probably an underestimate. The birth cohort studies that they follow for birth on suggest might get as high as a third of all men and 2/3 of all women. So it's probably more prevalent than we realize. Bipolar disorder is much less common. It's about 1 to 3% of the population. Unipolar disorder, not particularly heritable, less heritable than political preference. Bipolar disorder, quite highly heritable, is about as highly heritable as schizophrenia, almost quite as heritable as autism. And unipolar disorder, about twice as common in women as in men. Bipolar disorder, it's about an even split between the two.
Okay, so when you talk about treating depression, in your opinion, what are the most effective ways to treat depression?
Yeah. For unipolar depression, you've got your options. And for the majority of folks are not so severe that they would need hospitalization. And for them, there are an array of different psychological interventions. There's kind of a big three: cognitive therapy, behavioral activation, and interpersonal psychotherapy have all done quite well in controlled trials. And other kinds of psychotherapies probably would. They just haven't been as adequately tested. And then there are a number of different pharmacological medication kinds of approaches. The older MAOI, tricyclic, and more recently the SSRIs, the serotonin selective reuptake inhibitors. And the latter group are quite widely described. They're second only to the statins in terms of number of prescriptions worldwide, and relatively safe in the short run.
Okay, so the perception from a lot of times is you have someone going to their general practitioner and they start to talk about depression down on the long list of things that are impacting them, and the GP, for the most part, prescribes drugs to them.
Yeah.
What is your opinion as to how effective that is, or can that possibly even make things worse?
Well, I wouldn't necessarily say worse. The problem there is we're about twice as likely to use medications to treat depression in this country than they are overseas, places like England or Western Europe or Australia, and about twice as likely as we were 25 years ago. And that's because of the SSRIs. And most prescriptions for SSRIs are written by general practitioners. And I mean, they do the best they can, but they're not necessarily trained. And if somebody gets fully well on that, that's fine. But what happens a lot of times is it takes the edge off. The person feels better, but not fully well. And what a good psychiatrist would do if somebody got onto a psychiatrist is if the person isn't fully recovered, then they either increase the dose or augment or switch to another medication. And most GPs don't know to do that. So a lot of folks that get treated with medications by GPs, it takes the edge off. It's like taking an aspirin and only having half a headache.
Doctor, can you go back to, you mentioned SSRIs several times. Can you please describe that?
Sure.
So people can kind of wrap their head around what that is.
Yeah, sure. Those are medications like Prozac or Zoloft, et cetera. They're the most widely prescribed of the antidepressants nowadays. And the nice thing about SSRIs is you can't overdose on them. You can't self-poison with a suicide attempt. And you don't have to be all that careful about the older MAOIs. You have to be careful about what other kinds of food you ate, what other kind of medications you took. So they're safer in the short run than other medications. And once they came out back in the late 80s, early 90s, that's when general practitioners became comfortable prescribing antidepressants. Before then, they were reluctant to do that. And it's on the one hand, it's broadened the ease with which people can get access to antidepressant medications, which is good if they get fully well on them. But it's bad if they don't get fully well because the GPs just don't have the background to know how to handle some of the tougher to manage, but sometimes more effective medications for somebody that hasn't fully responded.
So do the SSRIs more just mask the symptoms of depression, though?
Yeah, I think it's fair to say mask is pretty close to the term. They suppress the symptoms, and any of the antidepressants do that. There's no evidence that any antidepressant medication does anything to the underlying episode. And most episodes of depression are going to run their course anyway. So usually 6 to 9 months or so, somebody's going to cycle out of it, even if they weren't getting treatment. The antidepressants are relatively effective in suppressing the symptoms, but they don't change the long-term course. And most folks who have had more than 1 or 2 episodes of depression are going to have more in the future. And what's happening is the field is moving in the direction of just putting people on medications and keeping them there lifetime. And whether that's really necessary is what's not so clear.
Okay, so you said so are you saying that a person who's had a depressive episode is more likely to have additional depressive
Yes.
episodes?
Again, if you take a look at the whole range of folks that get at least, let's say, unipolar depression, probably about half are never going to have another episode, or at least no more than maybe another one out there, but they rarely get into treatment. It's the folks that have had 2, 3, 4 episodes that do, and they're highly likely to have subsequent episodes in the future. And there's just no evidence that the medications keep you from having future episodes. And there's even some reason to think that maybe it's hard to get off the medications without the depression coming back. It might even prolong the underlying episode in a way that every time you try to come off, we're not as sure about that, but there's some possibility of that. So it's, again, that practice is moving in the direction of just not bringing people off medications.
Okay, so what type of specific therapies then would you recommend, or are the most effective in treating depression?
Yeah, for less severe unipolar depression, it doesn't matter much what you get. Everything works better than nothing, and nothing appears to work better than anything else, and that includes pill placebos. Placebos are quite effective for less severe depression, so just getting into treatment is a really good idea. For the more severe depressions, and we're not necessarily talking psychotic depression, cognitive therapy has good evidence behind it. It's as effective as medications for even more severe non-psychotic depression. Behavioral activation hasn't been tested as often, but it's done quite well in the trials. Relatively straightforward and simple kind of intervention. And interpersonal psychotherapy has also done quite well in the trials. All 3 of those have held their own vis-a-vis medications, and all 3 have beaten pill placebos in controlled trials. So we have a lot of good evidence that they work. And it's quite possible that some of the other psychotherapies work as well too. We just don't have as good a database on them. But you've got every bit as good an option with the psychotherapies, and certainly the cognitive therapy and behavior therapy look to have enduring effects. It looks like you cut risk for future episodes by about half relative to getting better on medications. That's why for example, the United Kingdom, they put £700 million into training therapists to do those kinds of interventions on the notion that in the long run that would be better for everybody. You wouldn't have to stay in treatment continuously. You wouldn't have to stay on medications. And there they would go to one of those interventions first.
Okay, so have there been any studies done that indicate that CBT or some other type of therapy actually changes the biology or physiology that impact or exacerbate depression?
Yeah. It's not as clear. It's possible. It might even be probable. And certainly somebody like Helen Mayberg at Emory has done some interesting studies to show that you get differential changes. Different parts of the brain change in CBT as opposed to medication. So that's suggestive. It may be even strongly suggestive. We do know that however it works, we do know that you get that long-term enduring effect. And that's been at least 8 studies out there, and 7 of the 8 have replicated. And it's quite clear that you get that kind of long-term preventative effect if you go into treatment with those kinds of interventions.
All right, now you have been a strong proponent that depression can be prevented.
Yep.
Can you start to go into that a little bit?
Sure. The kind of thing we just talked about for adolescents and adults, where if you're already depressed and you go into again, a cognitive or behavioral intervention, we have good, strong evidence that you get a preventative effect coming out. You're less likely to get depressed in the future. My wife is a developmental psychopathologist. She does work with children and adolescents, and she and her colleagues have trials that show that even before somebody gets depressed for the first time, you can provide those same, very similar kinds of interventions, cognitive, behavioral kinds of skills training interventions, that you you reduce the likelihood that those kids are going to have first onset or if they've ever had a prior depression, subsequent onset of depression. So we have good evidence that you can take folks that are not currently depressed but are at risk, and you can provide them skills training along the lines of cognitive behavioral intervention and reduce the risk that they're going to get depressed.
Okay, so when you say at risk, what exactly do you mean by that?
We know, for example, that anybody who's got family history, a parent with a history of depression or other family members is at elevated risk. If you've had a parent who himself or herself has had history of depression, about 3 to 5 times greater risk of getting depressed yourself. So we can identify who's risk, elevated risk, and those are usually the folks that they'll do those kind of prevention trials in adolescence. Again, I think of some of my wife's work and some of her colleagues who do interpersonal psychotherapy have done what's called a universal trial, where they just went into the school system. And if I recall, it might have been pre-adolescence, provided either a cognitive behavioral intervention or an interpersonal intervention. And in each of those interventions reduced the onset of depression down the line for the kids that got it. And they were not necessarily the same kids. So it might be that different kinds of preventative interventions work for different individuals, but they both got a preventative effect.
Okay, so if I'm a mom or dad, what are some signs that I'm beginning to look for in my kids that show that there may be an issue here versus the usual, let's say, teenage angst that they have, that Kathy, for example, has to live through? So can you start to go into what a mom and dad can look for?
A couple of things, and again, this is not my absolute area of strength, but I'm kind of going off what I hear from my wife and her colleagues. You look particularly for changes, and you look for a kid who has had friends, who's active doing things, who's not doing as much of that anymore. You see a real change in interest, and usually in depression, it's a loss of interest or withdrawal from things that they would typically do. A lot of times, when parents think of a kid as not being motivated, sometimes if you draw them out, what you really got going on is a bit of a depression. So parents often misread depression as a loss of interest or lack of motivation. It just doesn't care when in fact what's going on with depression. But you would especially look for evidence of change in an individual, in a child or a young adolescent.
All right, Dr. Hollon, don't go anywhere. We're going to continue the conversation during the break. We've got a great Facebook Live audience that follows us, and so we're going to continue the conversation. We're here at 1160 a.m. KBDT. If you're wanting to catch us later, go to JP, Kathy, and the crew on Facebook if you have a loved one or a family member that needs the information. We'll be right back after these messages.
Steve, one thing I forgot to ask you when we were talking about the drugs aspect. Can you go into a little bit what progressive resistance is?
Sure. Do you want me to do it now, or wait till we get back?
Let's start right now because we have folks tuned in on Facebook Live.
Okay. Yeah, progressive resistance is a name that's been applied to a particular phenomenon. 2 things. Number one, some folks who are doing just fine on the medication, still on the same dose, no big issues coming on, lose the responsivity to the medication. And it seems to be particularly likely with SSRIs, and it even has a kind of a slang term for it called taxal poop out. And nobody quite understands it, but it's about 1 person in 5 they seem to lose the response. Now, if you do that, a good psychopharmacologist will take them off that medication, maybe switch them to another, but at least take them off, and maybe a month later they go back on and get the response back sometimes. The other thing is that there's pretty good evidence. My colleague Jay Amsterdam, a good biological psychiatrist, published several studies on this, that the number of prior exposures to medication and antidepressants predict poorer and poorer response. So how many times you've been on medications in the past predicts that the more times you've been on, the less likely you are to respond to that same medication the next time on, and that's what he calls progressive resistance. Now, he thinks that means that you lose the responsivity to it. It could just be that sometimes you have to chase given patients with different medications to find one that works for them, and if somebody's not going to respond at all, they're going to have been tried on more different medications. We don't know if people actually change or if it's just a function of where you're going to respond or not, but there is that name for it.
Okay, so there's no evidence, though, that as your resistance builds up and you have to take more and more and more, there's not an addictive quality to that?
There's no evidence for addiction for the antidepressants in any kind of conventional sense. So, no, you don't have to keep increasing. It's not like an opioid. You don't have to keep increasing the dose to get the same kind of response. That's one of the things that makes it relatively good medication, relatively safe. And I should add, there's not the term is antidepressants, but the SSRIs are also the leading medications for anxiety disorders, virtually any kind of non-psychotic disorder. Nowadays, the primary medication you're going to use to treat with SSRI. And in that sense, they're not addictive. It's possible, and I want to really highlight the term possible, there's some reason to think that medications may lock in the homeostatic regulatory mechanisms that otherwise would have made the episode end on its own, so that at any time you stop taking the medication, it's like a coiled spring, it's ready to bounce back on. And the evolutionary biologist Paul Andrews talks about that. It's intriguing, and what he can do is predict how likely we are to relapse coming off of different medication
1 minute.
by how much it disturbs the underlying neurotransmitter systems. So it's not addiction per se, but it's a curious kind of phenomenon that may make it very hard to get off the medication.
Very good. And I think Patty has a few questions she wants to throw your way.
Yes,
Sure.
good morning, doctor. You mentioned a couple of times about subsequent episodes, and I'm wondering, does it take a stronger event to trigger a subsequent episode, or is it a lesser event? I mean, how severe of an event?
Yeah, the classical understanding is it takes less and less to trigger subsequent episodes. It goes back to Craigland. First, your husband has to die, then your dog has to die, then a bird, etc. And we have an easier time finding precipitants for a first, maybe a second episode than for later episodes.
10 seconds.
We're about to go back on air.
Okay.
Good morning and welcome back to JP, Kathy, and the crew here on 1160 AM KBDT News Talk Sports. We are super excited to be bringing you our mental health moment as we do every Tuesday at 8:30. We've got Dr. Stephen Hollon on the line. Very happy to have him calling in as an expert today. And then we also have Steve Dunn of the Morgan Foundation and Patty Giolot of Something for Kelly. So thank you all for being here. Steve, I'm going to turn it back over to you and the good doctor so y'all can continue the conversation.
Doctor, all right. So right before we went to break, we talked about signs that parents can look for. Once you see those signs and you want to get yourself and your kids into a therapy to address things, what type of preventive therapies are there out there?
Well, again, some of the same kind of things that look like they work for adults are also the best things that you would use for kids, adolescents especially. Cognitive therapy, behavioral activation, interpersonal psychotherapy are kind of the big three. But virtually any good counselor is going to be useful in that regard. For pre-adolescents, you're probably working more with the family, or you certainly want to work with the family and with the child being along or just being part of the process. Once you get to adolescence, you can do the same things you can do with adults.
Okay, so we also know that schools can actively get involved in as well. Can you go into the mindfulness training that exists in some schools?
Yeah,
what exactly is that?
Mindfulness really is a derivation of meditation. It's the Eastern approach that 3 billion Buddhists have been practicing for centuries. And it turns out to be quite effective preventative for depression. As you learn to really focus your attention, as you learn to be able to look at thoughts and just let them go without having a strong affective reaction to them, it seems to ward off depression from folks. And we're not as sure that it works to get you out of a depression if you're in one, but it's a good way to prevent subsequent episodes. And they're so taken with it, particularly in the United Kingdom, that they've got big, large, major trial going on now of doing it right through the school system, offering it to everybody. And it's kind of things like yoga or meditation. It's probably not bad for anybody, and it might well be quite good for those folks that would be particularly at need for it.
Okay, but being here in the States, though, we've reached a point in our public schools where art programs are gone and music programs are gone. Have there been any type of studies done, preventive care studies indicating that this mindfulness training is incredibly important and should be included in school curriculums?
Oh yeah, sure. And some of the major studies have been done in the States as well. As you and I were talking yesterday, the real problem in the States isn't that we don't have access to good, effective, preventive and interventions and treatments themselves. It's that our fractured healthcare system, we don't deliver them. Somebody like Sona Demijan in Colorado, Cheryl Goodman at Emory have done some terrific work with mindfulness and both with kids and with women approaching pregnancy. It does work, and it works quite well.
So if you were to give advice to moms and dads, to our people out there who may be suffering from depression, what would that advice be?
Talk to somebody, get some kind of treatment sooner, and at least go give something a try. Give it a couple, 2 or 3 sessions, see how it goes, see if it seems reasonable and feasible for you. But it's a much easier disorder to treat than most people realize. And one of the problems when you're depressed is you don't think anything's going to work for you, so you don't try. And it's so easy for parents, even well-intentioned parents, to miss because it looks like adolescent angst, or the kid's just not motivated. And a good professional can help you sort that out pretty quickly.
Okay,
If there's something there's nothing there, but if something there, it's not that hard to fix.
Okay, so how do you find a good professional? What do you look for? What are some questions you can ask them to see if they have the background that they need to help you?
Yeah, well, and again, it's not absolutely clear how much background they need to help, but I would take word of mouth. I would take other people in your community. For example, the area I know best, which is cognitive therapy, the Academy of Cognitive Therapy has a website which lists people that have been certified as being good at that particular modality, and they have contact information there. And you would hope it wouldn't be that hard to find, and I would ask around. I'd ask your general practitioner, and they'll have a pretty good idea.
Well, thank you so much, Doctor. We appreciate you being with us and being part of our mental health moment today.
Pleasure.
We look forward to talking with you again, and keep up the good work. Again, thank you so much for bringing such
Thanks.
great information to the crew.
Love it. Can I say one last thing very quickly?
Absolutely.
Bipolar disorder, for goodness sake, get on the appropriate medications, lithium, good stabilizer, stay on that. You don't have to psychotherapy that alone will work for that.
Great. Well, thank you so much. Great closing words. And thank you again to Steve Dunn of the Morgan Foundation and Patty Gillot of Something for Kelly. Everybody have a blessed day. We will be back again tomorrow. Of course, every Tuesday at 8:30, tune in for our mental health moment. The life that you save might be the life of one of your loved ones. Have a blessed day, and we will talk to you tomorrow.
Thanks, Kathy. See you.
You bet.
Facebook Live, thank you for tuning in.
Yes, do y'all want to say, Patty and
Thank
Steve,
you.
y'all want to say anything?
Yep.
Next week, we will have on one of our favorite guests.
Scoot over here so they can see ya.
Hello.
Hey.
Hello. Facebook Live next week, we're going to have on one of our favorite guests, Ms. Elisa Myers, the executive director from the Academy for Eating Disorders, who's going to be talking about the things that are going to be happening in the future, where the industry is going, and perhaps a whole lot of resources that you can reach out to for help.
Excellent. Patty, any words?
Absolutely. I was working with Lisa earlier, and another subject we're going to specifically cover, which is not covered often enough, standards of care for the patients. And as those are developing, I think that everybody's going to want to know, if you're a parent, a patient, a caregiver, you want to know if you're putting somebody into therapy or treatment.
What should you expect?
Yeah.
Oh my gosh, yeah, because it's something like when you go to you bring your kids to their regular doctor, or you go to your regular doctor, if you feel good, if you're sick and you get healthy quickly, that's how you know they've done a good job.
Yep. You don't know what to expect. You put your kid in a residential treatment center. What is the standard that you could reasonably expect?
Outcome?
Yep, absolutely. So we're going to talk about that next Tuesday.
Fantastic.
Going to be a good subject.
Yep, absolutely.
Oh, that's going to be a good one. Well, okay, so everybody tune in next Tuesday, but tune in all the days in between. So, please. All right. Love y'all. Have a great
guys.
day.
See you next
Bye-bye.
Tuesday. Bye.
We are booked up all the way.